Good morning, doctors. We are on a 36th day of reading Oxford Handbook of General Practice. Today, I am Dr. Sesha, your study buddy, and we are preparing together for MRCGP International Exam. And we are at chapter 17, Infectious Disease, page number 618, Immunization. Immunity can be induced in two ways. Active immunity induced using inactivated or attenuated live organisms. Immunity can be induced in two ways. Active immunity, induced using inactivated or attenuated live organisms or their products act by inducing cell-mediated immunity and serum antibodies, generally long-lasting. Passive immunity results from injection of human immunoglobulin. The protection afforded is immediate but lasts only a few weeks. So active is by vaccination, passive is by immunoglobulins. Storage of vaccines. Follow manufacturer's instructions. Do not store vaccines on the door of the fridge. Make sure there is a maximum and minimum thermometer in the fridge. Record readings regularly and discard vaccines if not stored at correct temperature. So there was one more question in the exam, so many times asked. Record the readings, and if you have to discard the vaccines if not stored at correct temperature. Administration of vaccines. Only suitably trained GPs or nurses should give immunizations. Check immunization is needed and the patient is fit. Check consent has been obtained and that immunizations are correct ones and in date. Ensure resuscitation facilities are available. Record this medicine expiry date and batch number. Reconstitute the vaccine if necessary and give according to manufacturer's instructions. Record date and site in the medical notes. Childhood immunizations. In the UK, routine vaccinations under 5 are usually done in the GP. Routine vaccination for older children are normally done through school health service. Schedule for childhood immunizations given in table 17.1. Adult immunization. Influenza and pneumococcal vaccination available as direct enhanced service. Existing practices do not have preferred provider service status. Additional payments are available through quality and outcome framework for ensuring at-risk patients receive vaccination. Other necessary vaccinations can be provided as an additional service. Opting out incurs in 2% decrease in global sum. A list of eligible vaccinations and terms of eligibility is available in the BMA website. It includes hepatitis A, cholera and typhoid vaccinations. Travel vaccinations that do not fall into these criteria can be administered as a private service. Contraindications to vaccination. For specific contraindications to individual vaccinations, consult the Green Book. General rules. Acute illness. Delay until fully recovered. Minor ailments without fever or systemic upset are not reasons to postpone immunization. So minor ailments which do not have fever or any systemic upset are not reasons to postpone immunization. Severe local reaction to previous dose. Extensive area of redness or swelling that involves much of the anterolateral surface of the thigh or a major part of the circumference of the upper arm. So there was a severe reaction to the previous dose, which is local reaction, that is redness, swelling involving anterolateral surface of thigh or major part of the upper arm circumference. Severe generalized reaction to a previous dose, fever more than 39.5 in less than 48 hours after vaccination. Anaphylaxis, bronchospasm, laryngeal edema or generalized collapse, prolonged unresponsiveness, prolonged high-pitched or inconsolable screaming for more than 4 hours, convulsions or encephalopathy less than 72 hours after vaccination. So these are generalized reactions and contraindication for vaccination. UK schedule for childhood immunization. Diseases: tuberculosis, BCG, high-risk neonates only, diphtheria, tetanus, pertussis, polio, Haemophilus influenza type B, Hib and hepatitis B. This is a 6-in-1 vaccine. So DTaP, IPV, Hib and Hep B. 6-in-1 vaccine, 2, 3 and 4 months. Again pneumococcal vaccine, 13 serotypes, PCV, that is a vaccine given to children, and pneumococcal PPV is given to adults. So PCV is given at 2 months, 4 months and 12 months. Rotavirus vaccine, given at 2 months and 3 months. Meningococcus type B vaccine, Men B, is given on the left thigh at 2, 4 and 12 months, same like pneumococcal vaccine. Meningococcus type C, Haemophilus influenza type B, these two are given at 12 months only, Men C and Hib B. Measles, mumps, rubella at 12 months, 3 years, 4 months. 12 months and 3 years, 4 months. Influenza vaccine, 2 to 17 years. Live attenuated influenza vaccina, La4, intranasal, both the nostrils. Less than 2 years, quadrivalent inactivated influenza vaccine, intramuscular. Annually, high risk in children plus all children aged 2 to 8 years. So, annually you have to give for high risk children and all children aged 2 to 8 years, and beyond that you can continue if there is any indication. Diphtheria, tetanus, pertussis, DTaP and IPV. This is 4-in-1 vaccine at 3 years and 4 months. HPV vaccination, HPV 2 doses 6 to 24 months apart, 12 to 13 years. Nowadays even single dose is advised of Gardasil. Tetanus, diphtheria, polio, TD, IPV, 14 years. Meningococcus ACWI, Men ACWI is again 14 years. Overcoming years will be extended to 2 to 17 years. Overcoming years. This one, the influenza vaccine, will be extended to 2 to 17 years in the NHS. Contraindications to live vaccines. Contraindications to live vaccines: BCG, measles, mumps, oral typhoid, rubella, yellow fever. These are the live vaccines. Do not give live vaccines to pregnant women or immunocompromised patients. Dose on high dose steroids more than 1 week, more than 1 milligram per kg per day prednisolone for children, or more than 40 milligrams per day for adults. If hematological malignancy is there, if radiotherapy, chemotherapy within 6 months, or another immunodeficiency syndrome. So any kind of immune deficiency or condition that can cause immune deficiency, you should not give live vaccines. Less than 3 weeks after another live vaccine, but 2 live vaccines may be given together at different sites. So you cannot give another live vaccine within 3 weeks time of another live vaccine. With immunoglobulin from 3 weeks before to 3 months after. So you should not give a live vaccine with immunoglobulin from 3 weeks before to 3 months after giving a immunoglobulin. Patients with HIV who are not severely immunocompromised may have live vaccines except BCG and yellow fever. Okay. BCG and yellow fever should not be given to HIV. Other live vaccines can be given. Vaccine damage payments. Only payable if a patient is more than 60% impaired by vaccination given within the NHS. Recipients receive a lump sum. Further information, you can see those links. Page number 620. Symptoms, signs and notification of infectious diseases. Specific symptoms and signs of infection depend upon infecting organism and organisms affected. For organs affected, for example, chest infection will cause respiratory symptoms, urine infection will cause UTI and symptoms suggesting infectious cause. Lymphadenopathy, palpable enlargement of the lymph nodes. Benign causes, infective causes, bacterial, pyogenic, tuberculosis, brucella, fungal, viral infections causing lymphadenopathies, Epstein-Barr virus, cytomegalovirus, HIV, toxoplasmosis, syphilis. Non-infective: sarcoid, connective tissue disease, rheumatoid arthritis, skin disease, eczema, psoriasis, drugs, phenytoin, berylliosis. So non-infective causes of lymphadenopathies: sarcoidosis, connective tissue disorders, rheumatoid arthritis, skin diseases like eczema and psoriasis, drugs like phenytoin and berylliosis. Malignant causes of lymph node enlargement is lymphoma, CLL, ALL, metastasis. Management in adults. Refer immediately for urgent investigation if rapidly growing, non-tender, firm or hard lymph nodes more than 3 centimeters in diameter. If the lymph nodes are rapidly growing, they are non-tender, firm, hard lymph nodes more than 3 centimeters. Lymph nodes associated with unexplained signs of ill health, night sweats, weight loss, persistent fever. Lymph nodes associated with other sinister signs, example a petechial rash, same day assessment, suspect head or neck tumor. Enlarged supraclavicular nodes in the absence of local infection. So if there's a petechial rash along with lymph node enlargement, you have to refer for same day assessment. Or if there is a suspected head and neck tumor. Most enlarged lymph nodes are reactive lymph nodes suggested by a short history, soft, tender, mobile lump and concurrent infection. If there are no sinister features, give these 2 weeks to settle. If not settling, check FBC, ESR plus EBV screen. So if after 2 weeks they are not settling, then check your full blood count, ESR and Epstein-Barr virus serology screen. Needed for lymphadenopathy more than 1 centimeter in diameter persisting for more than 6 weeks for urgent investigation. More than 1 centimeter and 6 weeks. Management in children. Refer to pediatrics urgently, particularly if there is no evidence of local infection. If more than one of the following is present: non-tender, firm, hard lymph nodes more than 2 centimeters in diameter, progressively enlarging lymph nodes associated with other signs of ill health like fever or weight loss, enlarged axillary lymph nodes in the absence of local infection or dermatitis, and supraclavicular lymph node enlargement. So when there is no evidence of infection and non-tender lymph nodes are there, hard lymph nodes more than 2 centimeters, progressively enlarging lymph nodes associated with other signs of ill health like fever or weight loss, enlarged axillary lymph nodes in the absence of local infection or dermatitis, and supraclavicular node involvement. Investigate with a full blood count and blood film if generalized lymphadenopathy is present. Normal temperatures as measured in different locations. So normal body temperatures is oral temperature will be 35.5 to 37.5 is normal. Rectal temperature 36.6 to 38 is normal. Axillary temperature 34.7 to 37.3 is normal. Ear temperature 35.8 to 38 degrees is normal. Pyrexia or fever. Oral temperature raised above 37.5 degrees Celsius. Normal range varies according to where it is measured. Common causes: infection. By far the most common cause in general practice is infection. Either it can be viral infection like HIV, EBV, URTI or influenza, chest infection, sinusitis, tonsillitis, cholecystitis, otitis media and cellulitis or UTI. Do not forget tropical diseases like malaria in patients returning from abroad. Think of TB and SBE especially in high-risk patients. Cancer, lymphoma, leukemia, solid tumors, hypernephroma can also cause pyrexia. Immunogenic causes: connective tissue diseases and autoimmune diseases like rheumatoid arthritis, SLE, PAN, polymyalgia rheumatica and sarcoidosis can also cause pyrexia. Thrombosis like DVT and pulmonary embolism. Drugs, antibiotics, fever in children less than 5 years, page 852, sepsis 622, rigors, shaking episodes, sometimes violent, associated with sudden rise in fever. Night sweats, considered tuberculosis. So tuberculosis, lymphoma, leukemia, solid tumors like renal carcinoma, menopause, anxiety states, drug causes and opioids. Drug causes which are opioids and SSRIs. These all cause night sweats. So opioids and SSRIs also cause night sweats. Pyrexia of unknown origin. Defined as fever either intermittent or continuous which has lasted for more than 3 weeks and for which no cause has been found. Recheck the history. Re-examine carefully. Check FBC, EBV screen depending on the age of the patient, ESR, CRP, LFTs, amylase, urine, microscopy and culture sensitivity. Viral titers including HIV, blood cultures, chest X-ray. If the cause does not become obvious, refer urgently for further investigation. So after testing everything, if you have not found a cause um, and fever is lasting more than 3 weeks, then you have to, then it is called as pyrexia of unknown origin. Notifiable diseases. Notification of certain diseases is required under Public Health Control of Disease Act in 1984 and Health Protection Notification Regulations 2010. Notification made on proper officer to the proper officer of local authority on forms available online. Diseases included are acute encephalitis, infectious hepatitis, acute meningitis, acute poliomyelitis, anthrax, botulinum, brucellosis, cholera, COVID-19, diphtheria, enteric fever, typhoid, paratyphoid, food poisoning, hemolytic uremic syndrome, infectious bloody diarrhea, invasive group A streptococcal disease and scarlet fever, Legionnaires disease, leprosy, malaria, measles, meningococcal septicemia, mumps, plague, rabies, rubella, SARS, smallpox, tetanus, tuberculosis, typhus, viral hemorrhagic fever, whooping cough, and yellow fever. In addition, notify other infections and contamination which could present significant health risk to human health. Chapter 17, Infectious Diseases. Sepsis. Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. It can be triggered by infection, and more than 1,47,000 people per year are admitted to a hospital with sepsis. UK 30% die with sepsis. Prompt recognition management saves lives. Patients at high risk of sepsis are age less than 1 or more than 75, frailty, age less than 1 more than 75, frailty, IV drug misuse, indwelling catheter line. Neonate, particularly if premature neonate less than 37 weeks, premature rupture of membranes or maternal history of infection. Immunosuppression, example chemotherapy, steroids or immunosuppressant drugs, splenic or hyposplenic sickle cell disease, diabetes. Invasive procedure within 6 weeks, example surgery, childbirth, miscarriage, top. Breach of skin integrity, example cut, ulcer, blister, burn. Initial assessment. If a patient presents with a possible infection, think this could be sepsis, particularly if the person looks ill or a family or carer is concerned. So whenever patient presents with a possible infection, you should always think it is sepsis and rule out sepsis first. Particularly if the person looks ill or family is concerned. History. High risk, ask about risk factors. Symptoms may give clues to source of infection like dysuria, coughing and cellulitis, or trigger concern, breathlessness, dizziness, cold peripheries, abnormal behavior. Ask about the frequency of urination in the past 18 hours. If assessing remotely, arrange to see if any risk factors or concerning features are present. Assess with extra care if communication problems like non-English speaker, dementia or dysphagia is present. Examination. Look for a source of infection. Examine for mottled or ashen appearance. cyanosis, non-blanching rash, any breach of skin integrity, example a cut, burn or skin infection, or other rash indicating potential infection. Check standard observations, temperature, BP, child only if the child cough is available, heart rate, respiratory rate, oxygen saturation, conscious level, capillary refill time, children less than 5 years. Risk stratification. Adults and children more than 12 years, figure 17.1. Children less than 5 years, page 852. Children aged 5 to 12 years, figure 29.12, page 1058. Management. If any red flag features, figure 17.1, admit via blue light ambulance to the hospital. So we will see in figure 17.1 what is the red flag features. Give oxygen to maintain peripheral saturations more than 94% while awaiting transfer. Provide clear handover to paramedics, example SBAR, page number 1035, news 2 score 1037. If any amber features are present, assess whether can be safely managed in the community. Example, consider admission if lives alone. If managed in the community, treat underlying infection as appropriate. Provide clear safety netting advice about when or how to seek further advice if there is any deterioration of concern. Consider arranging early follow-up. If less than 17 years and any immune suppression, admit. So amber flag features, if less than 17 years and any immunosuppression is present, you need to admit. Meningitis, meningococcal sepsis, page 1056, neutropenic sepsis, page 626. So these are the criteria. Category in the history, high risk criteria, moderate to high risk criteria, low risk criteria. So we will start from the green, not the red flags. Risk stratification tool for adults and children more than 12 years with suspected sepsis. This is sepsis tool, not fever tool. Risk stratification tool for adults and children more than 12 years with suspected sepsis. This is for adults and children more than 12 years. So the green flag signs are normal behavior in the history. Respiratory, no high risk or moderate to high risk criteria are met. BP, no high risk or moderate to high risk criteria are met. Circulation, no high risk or moderate to high risk criteria are met. Temperature, not there. Skin, non-blanching, no non-blanching rash. So that is green. Moderate to high risk criteria is history from patient, friend or relative of new onset altered mental or behavior or mental state. New onset altered behavior or mental state, history of acute deterioration of functional ability, impaired immune system, illness or drugs including oral steroids. So impaired immunity, illness or drugs including oral steroids, trauma, surgery or invasive procedures in the last 6 weeks. So this is moderate to high risk. Respiratory, increase in respiratory rate 21 to 24 breaths per minute. Systolic BP 90 to 100 per minute. Circulation, increased heart rate 91 to 130 beats per minute. Pregnant woman 100 to 130 beats per minute or new onset arrhythmia. Not passed urine in the past 18 to 12 to 18 hours if catheterized, pass 0.5 to 1 ml per kg per hour of urine. So patient has not passed urine for the past 12 to 18 hours. Tympanic temperature less than 36. Signs of potential infection. So this is hypothermia. Signs of potential infection including redness, swelling or discharge at surgical site or wound breakdown. That is skin conditions. So these are all moderate to high risk criteria. And high risk criteria, objective evidence of altered mental state. So in moderate risk, it is history from the patient. But high risk is when you are assessing the patient and you find objective evidence of new altered mental state. Respiratory, increase in respiratory rate more than 25 breaths, new need for oxygen to maintain saturation more than 92 or 88% if COPD, BP, systolic BP less than 90 or more than 40 millimeters below normal. So his normal BP was 140, then it is 100, that is also uh, high risk criteria. Less than 90 or more than 40 millimeters below normal. Circulation or hydration, increase in heart rate more than 130 beats, not passed urine more than 18 hours if catheterized, passed less than 0.5 ml of urine per kg per hour. So for a 60 kgs male, it will be 30 ml per hour of urine. And not passed urine, if not catheterized, not passed urine for more than 18 hours. Heart rate more than 130. Temperature, skin, mottled or ashen appearance, cyanosis of the skin, lips or tongue, non-blanching skin rash. This is for anyone about 12 years of age with suspected sepsis. Page number 624, illness in returning travelers. So whenever you have a question as in a patient returning from traveling, in all unwell returning travelers, consider imported disease in addition to the usual differential diagnosis. Tropical medicine is a specific field. If unsure, seek expert advice by telephone or admit the patient. History. Ask about symptoms, areas traveled to including brief stepovers, duration of travel, immunizations prior to travel, malaria prophylaxis whether taken or not, health of the members of the travel party, whether other people who have traveled with him are doing fine, sexual contacts while abroad, medical treatment abroad. Examination, full examination, particularly check for fever, jaundice, abdominal tenderness, chest signs, rashes and lymphadenopathy. Investigations. Depend on the symptoms and examination findings. Consider full blood count, thick and thin blood films for malaria, LFTs, viral serology, blood culture, stool culture, ensure it is fresh, and MSU, midstream urine culture sensitivity. MSU refers to midstream urine culture and sensitivity. MSU is not urine routine or microscopy, it is culture sensitivity. Malaria. 2000 cases per year are notified in the UK. Easy to miss. Symptoms. Malaria has a great mimic and can present with virtually any symptoms. Usually consists of a prodrome of headache, malaise, myalgia, anorexia, followed by recurrent high fevers, rigorous drenching sweats lasting 8 to 12 hours at a time. Examination may look normal. Look for anemia, jaundice or hepatosplenomegaly. So always examine an abdomen in a patient with fever. Look for hepatosplenomegaly and then you can come to a diagnosis easily. Investigation. In all the cases of fever in patients who have returned from a malaria endemic area, even if the plane just landed there and they did not get off, send a thick and thin film for malaria. If they have fever, they just landed in your country, just send thick and thin film for malaria. Management. Admit for further investigation and treatment if very unwell. Unable to check a thick and thin film. Example, presentation at weekend or out of hours. Thick and thin film is positive. Persistent fever despite negative thick and thin film. So in any of these cases, you have to admit for further investigation and treatment. Falciparum malaria caused by Plasmodium falciparum accounts for half of the UK cases. It may not present up to 3 months after return from a malaria endemic area, can be fatal in less than 24 hours, especially if it occurs in pregnant women or small children less than 3 years. Complications include cerebral malaria, 80% of the deaths, hypoglycemia, renal failure, pulmonary edema, splenic rupture, disseminated intravascular coagulation and death. So these are the complications of falciparum malaria. Benign malaria caused by P. vivax, P. ovale and P. malariae may cause illness up to 18 months after the return. All have very low mortality. Relapse may occur at intervals after initial infection or parasites lie dormant in the liver, P. vivax and P. ovale, or the blood, P. malariae. Typhoid and paratyphoid caused by Salmonella typhi and Salmonella paratyphi. 200 cases per year notified in the UK, spread by fecal-oral route. Incubation period is 3 days to 3 weeks. Symptoms. Symptoms of typhoid fever. Usually malaise, fever, headache, so cough. So cough is a symptom of typhoid fever. It was asked in one of the questions. Constipation or diarrhea. So there can be constipation or diarrhea. Nose bleeds, bruising or abdominal pain. Examination, there will be pyrexia, relative bradycardia, rose-colored spots on the trunk, splenomegaly, CNS signs of coma delirium and meningism. So typhoid fever or paratyphoid can affect the CNS also. Management, admit for further investigations and antibiotics. Prognosis, 10% die if untreated, less than 1% if treated, and 1% become chronic carriers after infection. Dengue fever. Viral infection endemic in tropical and subtropical regions. 150 cases per year are notified in UK. Spread by the day biting Aedes mosquito. Incubation period is 4 to 7 days. Symptoms and examination. Usually present with a flu-like illness, sudden high fever plus red maculopapular rash, plus or minus. A rash is present. Appears 2 to 5 days after the fever. Other symptoms are fatigue, headache, arthralgia, myalgia, nausea, vomiting, lymphadenopathy, skin hypersensitivity. Dengue hemorrhagic fever. Rare and severe form of dengue fever with poor prognosis. Purpuric rash appears 2 to 3 days after onset of symptoms. Minor injuries may cause bleeding, shock, death. Risk factors include previous dengue infection, age less than 12 years, and females and Caucasian origin. So this is dengue hemorrhagic fever. Rare and severe form, poor prognosis. There will be a purpuric rash appearing 2 to 3 days after onset of symptoms. Minor injuries may cause bleeding, shock or death. And risk factors would be previous dengue infection, less age and females and Caucasian. Management, admit, treatment is supportive. Travelers diarrhea. 50% of the travelers experience some diarrhea. Most cases last 4 to 5 days. 1 to 2% last more than 1 month. In all the cases, send a fresh stool sample for microscopy culture sensitivity at first presentation, noting on the form areas visited. Consider all the usual causes of diarrhea and gastroenteritis. In addition, consider cholera caused by gram-negative bacterium Vibrio cholerae spread by fecal-oral route. Incubation few hours to 5 days. Presentation profuse watery stool, fever, vomiting, dehydration. Management, admit. Treatment is with rehydration plus antibiotics. Giardiasis. 3,800 cases per year are notified in UK. Flagellate protozoan infection is suggested by an incubation period more than 2 weeks. Watery stool with flatus. Explosive diarrhea. No fever. Stool microscopy may be negative. If suspected, treat with metronidazole. Rapid response is diagnostic. Amoebic dysentery. 100 cases are notified in UK. May begin years after an infection. Diarrhea begins slowly becoming profuse and bloody, plus fever or malaise. Because it is dysentery, so it is bloody diarrhea. Diagnosis is confirmed by microscopy of fresh stool. Take specialist advice on management. Sexually transmitted infections, page 714, HIV 720, hepatitis 394, hepatitis BC 718, TB 296, meningitis 1056. Infection and immunocompromise, page number 626. Infections in patients whose host defense mechanism are compromised range from minor to fatal. They are often caused by organisms that normally reside on the body surfaces. Neutropenic sepsis, defined as a fever more than 38 degrees for more than 2 hours when neutrophil count is less than 1000. Chemotherapy, most common cause. Radiotherapy, if large volumes of bone marrow are irritated. Malignant infiltration of the bone marrow, example via prostate or breast cancer. Risk of neutropenia. Risk of bacterial fungal infection increase sharply as neutrophil count falls less than 1000. The greatest risk count at counts less than 100. Neutropenia for more than 5 days is a further risk factor. Patients are more risk in the nadir period from 1 week after therapy. Presentation. Mouth ulcers, increased fatigue can be signs of neutropenia. Symptoms and signs of sepsis may be minimal and deterioration can be rapid. Development of fever in a patient with neutropenia is a medical emergency caused by infection until proven otherwise. So, fever in a patient with neutropenia is a medical emergency until proven otherwise. Early referral for investigation and specialist management can be life-saving. Opportunistic infections. Infections from endogenous microflora that are not pathogenic or from ordinarily harmless organisms occur if host defense mechanisms have been altered by age, infection, burns, neoplasms, metabolic disorders, irradiation, foreign bodies, corticosteroids, immunosuppressive or cytotoxic drugs, diagnostic or therapeutic instrumentation. The precise character of the host altered defenses determines which organisms are likely to be involved. These organisms are often resistant to multiple antibiotics. Organisms commonly involved are E. coli, CMV, pneumocystis, candida, herpes viruses, toxoplasmosis, mycobacteria, non-pathogenic streptococci, cryptococcal infection. Expert care is always required. Refer promptly to the consultant responsible for the patient. HIV. Page number 720. Asplenic patients. All asplenic patients or functionally asplenic patients, patients with sickle cell disease, are at high risk of bacterial infection. Warn the patients about severe malaria and other topical infections when traveling abroad. Admit to hospital if infection develops, and despite prophylactic measures, ensure the asplenic patients have vaccinations. Table 17.3. Prophylactic antibiotics. Oral penicillin continuously until the age of 16 or for 2 years post splenectomy, whichever is longer. So you need to give them oral penicillin till age of 16 or for 2 years post splenectomy. Standby amoxicillin to start if symptoms of infection begin. So whenever you have to give them a standby medicine amoxicillin to start whenever infection begins. Patient health card or alerting health professionals to the infection risk cards and information referrals for patients available from website. Table 17.3. Immunization schedule for children and adults with immunocompromise, complement deficiency, asplenia or splenic dysfunction. At presentation, vaccination schedule. Less than 2 years at presentation. Routine childhood vaccination schedule. Further booster dose of MenACWI 1 month after the 12 to 13 month routine Hib and Men-C and PCV vaccination. So, a patient less than 2 years with immunocompromise or asplenia or complement deficiency or splenic dysfunction should receive all the routine vaccinations. Other than that, further booster dose of Men-ACWI more than 1 month after the 12 to 13 month routine Hib and Men-C and PCV vaccination. So at 12 to 13 months, you usually give MMR, Hib, Men-C and PCV vaccination. Immunocompromised, you don't give MMR because it's a live vaccine. You give a further booster of Men-ACWI and after 1 month, that is at 14 months. One further dose of Hib, Men-C and PPV at age of more than 2 years of age. So at 1 year you are giving Hib, Men-C and PCV vaccine, and then further dose of Hib, Men-C and PPV. This is PPV, not PCV, at more than 2 years of age. Pneumococcal polypeptide vaccine. 2 to 5 years of age at presentation. If already vaccinated with PCV 7, vaccinate with PCV 13, and then after more than 2 months with PPV. So initially, if you are vaccinated with PCV 7, which is routine in the vaccination schedule, you need to vaccinate the patient with PCV 13, and then after 2 months of that, you are vaccinated with PPV, polypeptide vaccine. If already vaccinated with PCV 13, vaccinate with PPV. Vaccinate immediately with Hib and Men-C booster. So Haemophilus influenza and meningitis conjugate vaccine booster. 1 month after Hib and Men-C booster, vaccinate with Men-ACWI. more than 5 years of age. Give Hib or Mense and PPV immediately. 1 month after Hib, Mense and PPV, vaccinate men ACWY. Here, PCV7 is pneumococcal conjugate 7-valent vaccine. PCV30 is pneumococcal conjugate 13-valent. PPV is pneumococcal polysaccharide given in adults usually. And Hib Mense is Haemophilus influenza B and meningococcal conjugate vaccine. And Men ACWI is meningitis quadrivalent conjugate vaccine. So if the patient is presented more than 5 years, give them again. Whenever they are presenting, you need to give them Men, Hib, Mense and PPV immediately. So all three you have to give immediately first. And then 1 month after Hib, Mense and PPV, you give ACWI. Prevention of infection. Antibiotics used for prevention of tuberculosis, meningitis in exposed patients who are immunocompromised. Recurrent UTIs, you need to give preventive antibiotics. Streptococcal infection in asplenic or hyposplenic patients, you give penicillin for up to 16 years of age or 2 years after splenectomy. Bacterial infections in granulocytopenic patients, you give prophylaxis. Pneumocystis in AIDS patients. Watch for signs of superinfection with resistant organisms. Active immunization has been mentioned in table 17.3. Passive immunization can prevent or ameliorate herpes zoster, BZIG, hepatitis A and B, measles, cytomegalovirus infection in selected immunosuppressed patients. If a patient is in contact with any of these diseases, ask for advice from the consultant looking after the patient or a consultant in communicable disease control. So the diseases which can be ameliorated are or prevented are herpes zoster, hepatitis A and B, measles and CMV. Immunoglobulin administration, effective for patients with hypogammaglobulinemia given on regular basis by IV infusion. Start vaccinations 2 weeks before splenectomy. Starting immunosuppression, suppressive treatment. So these vaccinations you have to give 2 weeks before if an elective splenectomy is there, and start immunosuppressive. If you are starting an immunosuppressive treatment in a patient, you give vaccinations 2 weeks before the start of immunosuppressive treatment. Page 628, childhood viral infections management. For the infections listed in table 17.4, management is supportive with paracetamol, fluids, antibiotics, secondary infection. So these are viral infections. So antibiotics if there is only secondary infection. Supportive paracetamol and fluids. Teething gels, example Calgel, may soothe the mouth lesions in the hand-foot-mouth disease if admit any serious complications develop. Prevention of measles, mumps and rubella. Measles, mumps, rubella vaccine consists of live attenuated measles, mumps and rubella viruses. Vaccine viruses are not transmitted. Offer MMR to all children after their first birthday and again at preschool. Reimmunization is needed if given to children less than 1 year. Children with chronic illnesses, example cystic fibrosis, are particular risks from measles and should be immunized. Malaise, fever and rash are common 1 week after immunizations and last 2 to 3 days. So there can be malaise, fever or rash. Advice for fever management: there is no link between MMR and autism or inflammatory bowel disease. Offer children aged more than 18 months who have not been vaccinated or whose vaccination status is unclear 2 doses of MMR vaccine. So initially you have to give, when they are vaccinated at 1 year, you give one vaccine at 1 year, another vaccine after at the preschool age, right, for MMR. But when the first vaccine has not been given at 1 year of age, then and patient is now more than 18 months have presented for vaccination, 2 doses of MMR vaccine 1 month apart should be given. If the child has received 1 dose of MMR, give a booster dose. Offer MMR to a woman of childbearing age who are not immune to rubella or not have had 2 doses of MMR or a seronegative. So, childbearing age, you need to give MMR vaccine. There is no evidence that vaccination in pregnancy is harmful, but do not give women known to be pregnant and advise whom are vaccinated to avoid pregnancy for 1 month afterwards. See, again, once you have given a live vaccine of MMR to a woman of childbearing age, ask them to avoid pregnancy for 1 month afterwards. Prevention of chickenpox. Offer chickenpox varicella immunization 2 doses 4 to 8 weeks apart to non-immune healthcare workers who have direct patient contact or susceptible close contacts of immunocompromised patients where continuing contact is unavoidable. So, close contacts of immunosuppressed patients. Consider those with a definite history of varicella infection, antibody test infection, immune antibody test, others. Vaccination is contraindicated if pregnant or immunocompromised. So, we are not giving vaccination in pregnancy or immunocompromised patient. Non-immune or immunosuppressed patients, pregnant women or neonates with significant exposure to the chickenpox or shingles should receive immunoglobulin VZIZ less than 3 days after contact. Check antibody levels if immune status is unknown. So, a pregnant woman or a neonate or a significant exposure to shingles, which is immunocompromised patient with significant exposure to shingles, should receive booster immunoglobulin VZIG less than 3 days after the contact. Check antibody levels if immune status is unknown. Shingles. Reinactivation of latent chickenpox virus. Reactivation of latent chickenpox virus. Shingles cannot be acquired by exposure to chickenpox, but contacts of patient with shingles can develop chickenpox. Infectious until all lesions have scabbed. Incidence 1 in 25. Any age, more common if immunocompromised. Presentation: unilateral pain precedes vesicular rash by 2 to 3 days. Crops of vesicles appear over 3 to 5 days and in distribution of more than one adjacent dermatomes. The affected area is usually hyperasthetic. Pain may be severe. Lesions scab over and fall off in less than 14 days. Management: treat as for chickenpox. Oral antivirals acyclovir 800 milligrams 5 times a day are only effective if initiated less than 48 hours after onset of rash. In shingles, if immunocompromised, admit for IV antivirals. Prevention: shingle vaccination routinely offered to adults aged more than 70 years in the UK. Complications: post-herpetic neuralgia, dissemination to other areas, immunosuppressed patients admit for IV antivirals, eye involvement refer urgently to ophthalmology. Ramsay-Hunt syndrome, page number 512. Table 17.4, common childhood viral infections. Measles, duration is 10 days. Main symptoms: incubation period 10 to 14 days. Early symptoms: fever, cough, coryza, conjunctivitis, lymph node enlargement. Measles, there will be lymph node enlargements. Later symptoms: scopic spots, tiny white spots on a bright red background found in the buccal mucosa of the cheeks. Rash, florid maculopapular rash after 4 days becomes confluent. Complications: bronchopneumonia, otitis media, stomatitis, pneumonia, otitis media, stomatitis, corneal ulcers, gastroenteritis, appendicitis, encephalitis in 1%, subacute sclerosing panencephalitis, which is rare. Rubella, German measles, 10 days is the incubation period. Incubation is 14 to 21 days. 10 days is the disease period. Incubation period 14 to 21 days. Symptoms of rubella: mild, may pass unrecognized, fever, lymph nodal enlargement including suboccipital nodes, pink maculopapular rash which lasts 3 days. This rash starts on the face, whereas measles rash starts on the hairline and spreads to the body. Maculopapular rash which lasts 3 days. Complication: birth defects if infected in pregnancy, arthritis in adolescence, thrombocytopenia is rare and encephalitis is rare. Mumps, 10 days. is the duration of illness. Incubation period is 16 to 21 days. Symptoms. Subclinical infection is common. Fever, malaise, tender enlargement of one or both the parotids plus submandibular glands. Complications. Aseptic meningitis, epididymoorchitis and pancreatitis. So treatment is again supportive. Chickenpox. Incubation period is 10 to 21 days. Infections 1 to 2 days. Patient is infectious 1 to 2 days before the rash appears and for 5 days afterwards or till all the lesions have crusted. Symptoms: rash plus fever. Spots appear in crops for 5 to 7 days on the skin and mucous membranes and progress from macule to papule, vesicle, then scab over. Complications are eczema herpeticum. Page 578. Encephalitis. Cerebellar symptoms are most common. Pneumonia, birth defects, neonatal infection. Page 795. Roseola infantum. Illness lasts 4 to 7 days. Child less than 2 years. Roseola or sixth disease. Symptoms: HHV6. Symptoms: high fever, sore throat and lymphadenopathy. High fever, sore throat, lymphadenopathy and macular rash appears after 3 to 4 days when fever is decreased. So the rash after the fever subsides is Roseola infantum. Erythema infectosum or fifth disease or slapper cheeks disease caused by parvovirus infection. Symptoms: again this lasts for 4 to 7 days. Symptoms: erythematous maculopapular rash starting on the face, slap cheeks, reticular lacy rash on the trunk and limbs, and mild fever and arthralgia which is rare. Contact with previous parvovirus in pregnancy can lead to non-immune hydrops. Hand, foot, mouth disease. 5 to 7 days is the period of duration of infection. Coxsackie virus infection. Symptoms: oral blisters or ulcers, red edged vesicles on the hands and feet, mild fever. So we are at page number 630. We'll stop here for today and tomorrow we will continue from page number 630, streptococcal and staphylococcal infections. Thank you. Have a good day.